Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm delighted to be joined by Dr. Bala Nair. He is the Chief Technology Officer for Perimatics. He's also an Associate Professor at the University of Washington. And Dr. Rajeev Saxena, he is an anesthesiology or an anesthetist resident, as I would say, also at the University of Washington. Rajeev, Bala, thanks for joining me today.
It's our pleasure, Dr. Nick.
Same here.
So we connected as a result of a paper that both of you published, or there was a number of authors, but obviously the two of you are key contributors to this, talking about operating room efficiency and machine learning, which I want to dive into, and that's really the sort of focus of the show. But before we get there, tell us a little bit about your backgrounds. Bala, if you'd start off, and then Rajeev, just tell us how you got to where you are at this point.
Thank you, Dr. Nick. My background is actually in biomedical engineering. So I happen to be an engineer that landed in the space of perioperative clinical care. And I've spent the last 25 years trying to see how technology and informatics can improve patient care efficiency in the perioperative setting. So I spent my years here at the University of Washington as well as at Cleveland Clinic. And recently, I moved on to an industry position where I became the Chief Technology Officer of Perimatics. So that's my background.
Fantastic. And Rajeev, you're a little bit unusual. You're clearly a glutton for punishment, since you've got at least 2 residencies, not fully completed, but you've been through at least 2 of them, right?
Yeah, no, that's absolutely right, Dr. Nick. So I'm Rajeev. I'm an anesthesiology resident at the University of Washington, and I was previously a head and neck surgery resident here. For me, I feel like I constantly immerse myself in medicine, but I'm constantly tinkering with kind of the boundaries and figuring out what we can borrow from other disciplines. And just as kind of a few examples, kind of from a creative standpoint, last week I launched a satirical children's book on Amazon called The ABCs of Medicine.
Wow.
So kind of some ways to entertain babies and young professionals. As a resident, we're kind of the front line in the hospital, and burnout's a huge stigmatized problem.
Yep.
So I have a coaching service that I'm working to solve this problem for professionals in pressure cooker environments. And then from a system standpoint, both as a surgical resident and now an anesthesia resident, it's very interesting, right? Because you can predict how long it takes. If Bala and I jumped in a van and drove to Boston, 3,000 miles away, you can predict that with pretty high accuracy. But you go into our domain, the hospital, and you get shoulder shrugs and guesses for almost everything. So that journey led me to try to figure out how we can use perioperative analytics to really improve our systems and ultimately solve problems that matter for us.
Yeah, it's fascinating. I mean, you talk about that, and it never ceases to amaze me how accurate that prediction for the time taken to get from A to B. I mean, it's at the point where I don't even need to leave the sort of 30 minutes of extra lag time because it's so good. But you're right. We come to medicine and people go, huh, what? So that's what you've tried to solve. That's your sort of, well, not solve, but you've sort of focused on. Tell us a little bit about how the two of you came together. I think there's always a story in that, because as we try and improve medicine, I think one of the things that I consistently hear is we don't have all the answers. And here you've come to, how did that happen? How did you two come together on this project?
So I can explain my angle of the story. I was a former director of a perioperative Center for Perioperative Quality Improvement Institute at the University of Washington. And the goal of the center was to use technology and data particularly to improve quality efficiency in the perioperative setting. And Rajeev was a resident at ENT surgery resident at that time. And then he expressed interest to improve efficiency. And one of our common colleagues introduced both of us, and that triggered in a good collaboration, and we did this project together. So that's my take on the story. Rajeev, anything to add?
Yeah, I would say one thing, Dr. Nick, sometimes I think many of us who work in healthcare, as physicians really see this, is that it can feel at times like you're powerless, right? The practice of medicine is quite different than the delivery of healthcare in systems. And I had remembered back when I was at Tufts Medical Center, how an anesthesiologist really was able to use data analytics to actually be able to answer questions. And, I found myself, several years into residency here, kind of having a lot of the same questions, like, how do we improve efficiency? Like, what are some of the bottlenecks in the system? And so John Lang, who's the director of operative services here and an anesthesiologist, was very eager to sort of incorporate perioperative data analytics and statistical approaches to improve care. And so through that collaboration, I met Bala, and it's been we've done a number of projects since then. It's been very exciting and very practical.
Fantastic. So as you think about this particular issue, and what really struck me about this was the prediction aspect to it. So we mostly can predict that a specific case, assuming it's routine, is this period in time, but you really dug deep into this in terms of the concept of predicting down to an individual level using data. So tell us a little bit about the journey as to how you got to this, and some of the details about the study, because this is a substantial study, right, with some great results.
Happy to talk about that. So, Dr. Nick, this question, we started with, I would say, a very simple question. How long does an operating room case take? Or how long is a surgery? This has been a question, I think, for decades people have tried to answer. And I would kind of liken it to this, like the operating room scheduling, it's like putting together this giant jigsaw puzzle, right? You want to get all the pieces to align so that way you can kind of optimize your use of the operating room. The problem for somebody scheduling the operating room is that you just don't know how big the jigsaw puzzle piece is, right? If every kind of case is sort of an estimate, then you can run into times when you're not using the operating room efficiently, or times when you have too many cases and have to cancel cases. And so from our standpoint, the operating room is a system within the hospital. It's one of the most expensive and one of the most profitable centers in a hospital. And so it's a key driver. So we started with kind of, I would say, a very fundamental question, a very basic question, and then sought to really do it at scale across surgical service lines and with nearly 47,000 cases to really try to see if we could improve how we allocate our operating room time.
So, Bala, as you thought about this, obviously, years of experience focusing on sort of optimization, what were the key elements of that data set that you were looking for? And, how did you dive into that to start to drive this process? Because I look at this and, my reaction to this is very much the same way as Rajeev. It's, huge jigsaw puzzle. It's completely beyond my capacity to sort of process. How did you start that? What was your first step?
So I think the first step is obviously getting the necessary data. So what advantage we had was that through our Center for Perioperative Quality and Efficiency, we had a very comprehensive data set that comprised of patient, procedure, and personnel. Personnel meaning surgeon, anesthesiologist type data. So that data was available, and we were hosting that data for multiple research purposes. So that gave us the impetus, that gave us the basic foundation to get on with this project. And the unique thing that we did was that we wanted to look at it as broadly as possible. So other people have probably looked at it in just in a more narrow fashion, in the sense that they will be focusing on particular surgery service line specific predictions, or they could be looking at just the procedure factors and not including the patient factors. So we went ahead and looked at the patient, procedure, and personnel factors, all the parameters that can potentially influence the duration of surgery. So that was what our, I think, differentiating factor was, essentially. You look at
and as you dug into that, so one of the things that strikes me, same procedure, it wouldn't be the same patient. That would be unusual, but, trying to control for things. But, the variation, I would imagine, it attributable to the individual surgeon. And obviously there are contributing factors, but was there anything that sort of came out as part of that process as you dug into that said, wow, we learned something about this surgeon, maybe he has more complex cases? And how did you sort of normalize for those elements of data? Because I just sort of think about this in my experience in the OR, and it was just widely varied, although quite often we had an intuition that said, oh yeah, that's Dr. So-and-so, it's going to be a long case, not because he was slow, but because he had the complex cases. How did you sort of approach that?
Yeah, so yeah, Dr. Nick, so I would say we approach that by actually analyzing our data and developing models in different ways. So we started very broadly first, which is if you look at 4 years worth of data, nearly 47,000 cases, and kind of input all of that information so that patient, procedure, and personnel factors, what are sort of your best estimates? But then we also sort of said, hey, we have 12 surgical service lines. Vascular surgery is probably different than neurosurgery, which is different than, orthopedic surgery, right? In terms of the complexity and the types of cases. And so we kind of divided different models, fine-tuned per service lines. And then ultimately, our kind of highest performing models, and one of the key takeaways for our study was a composite model with individual surgeon specific models was actually the highest accuracy in prediction. And one of the key reasons why we think that's the case is that there's so much variability when you look at it from a system standpoint. But if you know who the individual surgeon is, he or she may have more complex cases. They may be an oncologic surgeon, in which case there may be higher variability depending on intraoperative findings, right? And so if you fine-tune models for individual surgeons, you actually can have like the best predictive capabilities. And that's ultimately very data intensive, very computationally intensive. But our kind of highest performing model was a composite of 95 individual surgeon specific models.
So for those of you just joining, I'm joined by Dr. Bala Nair. He is the CTO of Perimatics and also the Associate Professor at the University of Washington, and Dr. Rajeev Saxena. He is an anesthesiology resident at the University of Washington. We were just talking about their model, improving operating efficiency, and diving into the parameters. And one of the challenges with that data is, I know you said you had good data, right? But what was the quality of it like? Was it high quality? Was it normalized? So could you make comparisons? Did you have enough, or was it full of sort of gaps, hole? How did you sort of approach that issue? Because quite often the data quality impacts these models very early on.
So this was an effort that has been ongoing for the last few years at the Center for Perioperative Quality and Safety. So the way we got data and ensure that the quality is good is to obtain data from multiple sources. So we have in the perioperative setting, we have the anesthesia information management system, which is one source of data. The nurses keep their documentation of how long the surgery is going on. So we take data from these multiple sources, and if there are duplicates of documentation from different sources, we combine them and make the best source of data, combine together and select the best source of data from whichever system it comes from. So by using multiple sources of data, by using artifact detection techniques, we could eliminate, procedures that are really, not really correct, physiologically correct. So when we bring this data into the data platform that the perioperative center has hosted, we already do some of these corrections. We already have selected the best source of data. So that's the best that we could do as far as, providing that data into these AI models to predict coagulation.
Fantastic. So combining multiple sources, reconciling that, I imagine, was something of a challenge. Obviously, you overcame that because, different sources, different reference data points and so forth. But obviously, you managed to achieve that. And you came up with, best source. So, I find that fascinating, where are those individuals? And I don't know if you're able to sort of tease that out, but what were the best sources of data from a predictive standpoint in terms of the information, the results? Do you have a sense of that?
The nursing documentation, believe it or not, were somewhat better than what the anesthesiologist.
You say that as if you're surprised, but I think every physician knows that, right?
Maybe because even
more accurate, better done, better quality.
Yes, I think they're probably more systematic in documenting things. While the anesthesiologists are probably busy keeping the patient alive and taking care of the patient, so they are, there's more things in their mind to do as compared to documentation. That could be a reason.
I think that's fascinating. Potentially a learning point for other AI models is to say, let's pay more attention to the nursing documentation, which, historically, I feel like we haven't. And, there's some great utility in all of that source data that's high quality. That was always number one, I could read the nursing notes. I could never read the physician notes. So, that was in the days when we wrote this stuff. So, So tell us a little bit about the results. I think if I interpreted it right, you guys nailed it pretty much, right?
Well, I would say we were able to significantly improve our accuracy, which was I would say a novel finding given the scope of our study. And so specifically, we were looking at almost 47,000 cases and comparing the standard, which is how most cases have been scheduled since the beginning of time, which is kind of a surgeon will perform some mental gymnastics, taking into account day of the week, complexity of surgery, likelihood to do sub-procedures, and come up with a number. And the surgeons are pretty good at this. They have the ultimate thing that our data sets can't quite capture, which is the intraoperative variability. Right. And so we compared that standard to kind of our model based on, individual service line and individual surgeons. And what we found was you could basically go from less than a third of cases being accurately predicted to nearly half of cases being accurately predicted with our top performing models. The devil is always in the details. And so certainly there are certain surgeon models which are much more accurate than other ones. So that's kind of an ongoing area of study for us. But I think if you look systematically at why we're able to better, perform these estimations, I think the reality is, there's kind of a systematic tendency to underestimate how long a case should take. And so we're much more able to kind of have a normalized bell curve, so to speak, with our model. So that's one aspect. But the second is just the sheer volume of data, right? So, in our model, we don't just incorporate the historic data, for the procedure, but we look at, tonsillectomy. How long did the average tonsillectomy take for all surgeons performing it? How long did, all tonsillectomies performed by that individual surgeon take, right? Looking over years, looking at all of the, sub procedures. And so the sheer amount of data that's captured in there is very, I would say, fundamentally different from how we currently estimate case duration. So I think it's exciting, our work, because in many ways, we did it at a systems level, looking at all surgical service lines with, implementation in mind, which is something we've been working on too in the last year.
So were there any standouts that you can share in terms of surprises of that learning between the difference between, and that the fact that surgeons were not bad, not great, but not bad at estimating is, testament to all of that sort of experience. And the fact that this thing, the brain is a pretty good computer ultimately with, all of those factors. Anything that surprised you that you learned from the output?
Yeah, I would say, first off, I thought that initially that we might be able to really kind of have the highest accuracy predictions ever. And I would say one of the humbling points, and it's an important point in data science, especially in the perioperative area, is that there are certain limitations. One is data integrity. So we talked about some of the pitfalls, the challenges, missing data. Certainly, I think you need to have clinicians very actively involved in this process because there are certainly artifacts that develop as you're doing analysis. Right. So one is kind of that access to data, data integrity. And the second is, what metrics are you actually measuring? So the hardest area to capture, and that we don't quite have it in our data set is, you're doing an abdominal surgery. What is the likelihood that there may be cancer in there, right? If there's cancer, that might necessitate several other operations. It might add several hours to the operation. And so there are ways that surgeons kind of incorporate, this into their informed consent, into their procedure codes that we can actually extract for our data analysis. But probabilistic aspect of like what is the likelihood that all of those things are done is still hard. So there's still a very high standard deviation in estimation. So I think it's humbling. It shows that there's still a lot of potential to make improvements. I would say that's one kind of takeaway. Another one is that by virtue of including all of these service lines, I would say, such low-hanging fruit, right? We're able to improve estimation when you look systemically by, I would say, a very large dividend. I mean, going from less than a third to nearly half of cases being accurately predicted, right? So despite our opportunities to get even better already right now, just applying data science, you can really make substantive change.
Fantastic. So, Bala, as you think about this from other places, I mean, I would read this working in another institution and go, I want that. What's the scope to be able to take this? I don't want to say generalize it, because ultimately, we have operating rooms, and but do they have the data? What's the potential to take this and start using it in other places? Because that's obviously the opportunity here, and I'm sure there are people listening going, get me some of that. I'm tired of sort of the inefficiencies that we have just in the OR, let alone in the other places.
Mm-hmm. I think what we learned through this project is that we know that the best approach is to create surgeon-specific model. That I think we're very confident as part of the study. So we have a good starting point. If you go from hospital, from our hospital here to any other hospital, we know this is the approach we need to take. But there will be variations from one hospital to the other. Their definitions of procedures would be different. Their workflow will be a little different. So we have to customize. We have to train these models with the data from that next hospital. But so I would say, with the approach being known, we still would like to have data, maybe 3 years worth of data to train this model. And then from that point onwards, we're hopeful that we can replicate the same results that we have at University of Washington.
So is it fair to say minimum 3 years of data, and what sort of data? I mean, you obviously had a rich set of content. Do you think most places would be able to satisfy that, or is that going to be a challenge in some instances?
So that is also something that we can provide as part of the company that I'm part of. One of the key features that we bring out is a data platform that extracts, normalizes, and then corrects for data acquired from a different electronic medical record system. So that's why, that it is really a good point that you brought up, Dr. Nick, that we have to have good data so we can help with that, plus our data science expertise in translating the results at University of Washington to another hospital.
Okay, fantastic. So in the closing minute or so, just share a little bit of where you see this going, what the opportunities are. Obviously, you've gotten to a level of accuracy. I mean, I think that's extraordinarily exciting. Very expensive resource, underutilized, frustrating. What's next? What are you going to be up to in the coming months?
So right now we're very actively involved in implementation, and I would say if there's one takeaway, this is it. You have to build fair process. You have to build a coalition. In medicine, trust is so important, right? So even if our models are able to more accurately predict a case, the next question is, what do you do with that information? Are you going to override schedules according to it? How do you actually do this in a way where you can bring out the benefits of the model while still kind of helping the organization? And so for the last 10 months, we've been doing this as a prospective implementation at the University of Washington. And we've actually found our results are similar, if not better, prospectively. It's been a very slow, steady implementation. And so you have to have your administrators, you have to have conversations with schedulers, with surgeons. And that is probably the most important part is really building that collaboration so that you can then go forward with your models and bring about the system improvements that we all want.
So in addition to the prospective implementation, we're also doing work on optimizing, using this predicted duration. How can we fit in the necessary number of surgeries within the blocks that are assigned. So we do this optimization based on the OR duration prediction, so we can make sure our schedules are optimized. So that is also another step that we are trying to do.
Fantastic.
So essentially, the goal is to translate the machine learning models into practical applications.
Fantastic. So unfortunately, as usual, we've run out of time. So it just remains for me to thank you. Rajeev, Bala, thanks for joining me on the show today.
Thank you, Dr. Nick. It was our pleasure.
Thank you very much. It was our pleasure too.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, #TheIncrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.